Those policies do it every 72 hours, 96 hours, or if you're doing it every Sunday or whatever the case may be. Explain to them what you're doing, exactly what you're doing beforehand, because they're already pretty apprehensive about this line. They know it's important. They know they have to keep it clean. They know they have to keep it safe. So you're going to be pulling off on tape and stuff like that. Just let them know that it's normal maintenance. It's in order to keep you infection-free. And everything that you go through is just for their safety. You always want to make sure that every hospital has a different type of central line dressing change kit. All the kits have different things in them. You always want to make sure that wherever you're working, you become familiar with what's in the kit. So in this kit, whenever you're opening it up, you have one mask on top. Now you can either have the patient wear a mask or you can have them turn the opposite direction. All the kits that we have now, they come with two masks. So one mask for you, one mask for the patient. You should always put a mask on. So one mask for me, one mask for the patient, and you guys can put it on like this. Just make sure that it sits on there somehow. You can have the patient also turn their head to the right or the left, depending on what side the body that the central line is on. It comes with sterile gloves, so you can use those if you want, and I'm going to show you what's in there. It has a sterile drape, the Tegaderm, the iodine, which we're not going to use. There's another little iodine swab in here as well, which you're not going to use, and the alcohol wipes. And there should be some more tape, some gauze in case you have a little bit of exudate or a little bit of bleeding. And then you also have forceps. So with all of that said, you have it open, and the newer ones all come with the chlorhexidine little bio patch in there. So you always want to make sure that you ask the patient if they're allergic to iodine, chlorhexidine. You never know. If they're allergic to iodine, obviously you're not going to use that. And if they're allergic to the chlorhexidine, you're not going to use that as well. But those will be individually wrapped in little packages inside the central line dressing kit. And there is also tape measure in here, and the tape measure is used for measuring PICC lines, because they don't trim the ends of PICC lines. That's the only way that you can inspect the tip when you pull them out, is to see that they're not been trimmed, because there have been cases now that little portions of the end have broken off from insertion. Maybe the transducer or something like that made it to where it cut it or something like that, and it's circulating in the patient's body, the little tip. So that's why whenever you pull anything out, whether it be a catheter, a peripheral IV catheter, or a central line catheter, you always want to inspect the tip, make sure it's intact. It doesn't look like it's all chewed up or broken in half or something like that. Wash your hands. You have gloves on. You know what's in your kit. You also have another pair of sterile gloves if you need them, especially if you've gone through your kit and you know that those gloves don't fit you, which they don't fit me. I always make sure I bring an extra pair of sterile gloves just in case I mess up or I put a hand through one of these gloves and you have the patient exposed. You don't want to have them exposed and then leave the room and then come back and then something had happened, they vomited on there or something like that. You never know what could possibly happen. So with that said, you always want to make sure that if you're doing anything, if it's absolutely necessary that they have things running, then you leave them running. But if not, you can turn things off or make sure that they're clamped. You always want to inspect the site. Look for any redness, swelling, any discharge as soon as you take this dressing off. And most of the time, you should be able to see the site. You can use alcohol to help you, especially on these mannequins. You'll see that the Tegaderms stick really, really tight to the patient. Yeah. Yeah. So it'll likely end up sticking to your fingers. Now, whenever you're taking off the dressing you always want to take it off in the direction that the line is going into the patient. So you'll never have a line that's going this way because it's going away from the heart. Everything will always be going this way. So you always want to make sure you're taking dressings off in this fashion so that you don't end up accidentally pulling the line out. Maybe they have it sutured in there and this is the 5th week that they've had their dressing changed, and that suture has just started to protrude out of the skin, and you go and you pull it down like that and you pull the line out by accident. or you pull it out, 2.5 inches. You don't just go sticking it right back in there. You have to take it out, call the doctor, and tell them what happened. They're going to scream and yell, and then they're going to have to come place a new one. Or they'll be like, you know what, you deal with it. Is the patient on pressors anymore? No. Well, it's your fault. You figure it out. Write an event report. So you're going to make sure that you get all of the stickiness off of the mannequin, especially because it's quite difficult sometimes. And especially with the larger tegaderms, you'll find out today that they don't come off so easily.
At least they don't have hair.
Yeah, and if they have hair, hopefully it's been clipped, but as people start growing their hair back, the dressings don't stick anymore. So sometimes you have to shave them again if that's possible. So once I get the dressing off, I always keep my finger, because I can't see what's underneath there, I'll keep my finger on the hub or on the portion that's holding it inside the patient. Usually there's that little chlorhexidine strip that's underneath there, or the actual anchor that's on there. Pull all this off, and you're going to pull off the old dressing with the direction that it's going. So if I pulled it off like this and it was stuck to it, it would pull it out, most likely, because it's not sutured behind on most patients. This is a mannequin. So if I pulled it out this way, especially, that one's stuck in there good, you could accidentally pull it out. Say one of these sutures wasn't in there, or the person whoever sutured it didn't do a good job, and they did it very superficially, and you're kind of like, oh, it's kind of stuck, and you pull on it a little bit, and it pulls it right out. You don't want that to happen. So you're going to make sure that you take the dressing off just like this, and then you'll discard that. Take your now dirty gloves off. Perform hand hygiene again. And with this, you guys have put the gloves on enough times to know that you got to let your hands dry. And if your hands are sweating, you got to let them dry. Talk to the patient, ask them what they have for breakfast, what's going on. Make sure.
Clean gloves.
Yeah.
Mm-hmm. If that thing was to come out, would they start pouring out?
No. If the central line does come out, you want to lay the bed down. You don't want them to be high up, because usually when you're doing this, either they're sitting up or they've got the bed up at a 45-degree angle, and it's to where that you can work with it. You have the bed at a working height and everything. They're pretty much just like this, so that you're not bending over them working on them. If it does happen to come out, you apply manual pressure to the site with a gauze and or just regular gloves until you can get some gauze there. Pull the line out, hold pressure there for 3 to 5 minutes, and after that 3 to 5 minutes, you'll inspect to make sure it's not bleeding. And if it's not bleeding, you'll put a clear dressing over the top, call the doctor, let him know what happened, and make sure that the patient just stays lying down for at least 20 minutes, especially if it's in the interjugular area or the subclavian area. You want that area to heal without a lot of force. So if they're lying down, it's a lot less resistance on everything. So at least 20 minutes for that, and then they should be good to go. So next, you put your mask on the patient. You have your latex gloves if you want, or the sterile gloves from the kit if you want to use those. You can use this sterile drape in here to put your things on top of if you need to. If you're familiar with what's in your kit, you typically shouldn't need to. So you know everything that's in there. The patient's not allergic to chlorhexidine, so you got that in there. So now you have your sterile gloves. If you wanted to, you could use this thing. You can put everything on there. Or if you want to use this is all still sterile, because I've touched it with sterile hands only.
What about your mask?
I have my mask on already.
You put that on first?
Yeah.
Okay.
So some of the kits that like these don't come with 2 masks, you would have already put yours on. If it comes with 2 masks, you can put it on, then wash your hands afterwards. So you have your dressing, you have your alcohol wipes, you have your chlorhexidine, which comes in its own package, and these all come with a little gauze that looks like a, oh, see the tape gets all caught in there. You would use this if your kit, on the day of checkoff, if we run out of the green things, you're going to use this. Okay? And whenever you put it on the patient, you're going to put it on in such a way so that whenever you take it off, it comes off. So you don't put it on and turn it around and make it sideways or upside down or anything like that. So when it goes on the patient, it goes on in a way so that whenever it actually comes off, you're not going to accidentally pull on anything. Because if you put it on the patient like this and then you turn it, when you go to pull it off, it's going to pull on the bottom of the line. And I'll show you about that in just a second. So you have everything that you need. Your hands are still sterile. You're going to open up your alcohol wipes on the mannequin, because on the mannequin we're only using alcohol. And then you have your forceps. So you're going to come over to the site and you're going to do concentric circles around the site. And if this is sutured in there, you're not going to be able to pick it up like this. So if it's sutured in there, you're pretty much just going to be going around like this on a real patient. But on this one, you can go all the way around. That's 1, 2, and then the third one. And the kits that we have at the hospital now do not come with forceps in them. So I'm just letting you guys know, every hospital is different. And you can clean the lines as well. You always want to make sure you clean the lines. And no matter what you're using, whatever the solution is, alcohol, chlorhexidine, you're always going to make sure that it dries. You know, you're not sitting here breathing all over, because we both have masks on. And if it starts bleeding, you can dab it, dab it, dab it. But you guys should all have plenty of these chlorhexidine tabs. And whenever you go and put those on the patient, if they're sutured down, you're going to have to try to, finagle it in there. Sometimes all you can do is just put it over the top, just like this, because it's sutured down so tight, you're not going to fit it underneath there. But on these mannequins, you should be able to fit it to where it's going to go right around the top of there.
So if you don't have forceps, do we just grab that with our non-dominant hand?
Yes, you have the sterile gloves on, so I mean everything's sterile. Once you've cleaned the area, you just don't want to be like this. Trying to touch them as much as possible. You want to just, you have your clean sterile, your sterile gloved hand, and you're touching this, and you're moving this around, but those little chlorhexidine tabs are a lot smaller. You don't want it to be like this. Because whenever you go to put the dressing on there, it's going to stick to that, and whenever you go to try to pull it off, it's going to pull this on there like that. So that's why I'm telling you guys, whenever you put these little chlorhexidine tabs on there, you want to make sure that that little breaking point is right near underneath where the line is. So that whenever you go to pull it off, it pulls off just like that. Does everybody understand that?
Mm-hmm.
So
for the pass off, you might just have to
it could be, but it looks like there's a big box of them. But if people go through them and they end up throwing them all away, that's another thing. Make sure you keep the chlorhexidine tabs. They come off of the tegaderms really easily, so don't throw those away, okay? Because they're going to use those for the times to come. If you have it turned like this, whenever you go to pull it off, it's going to get stuck on there. So try not to do that. So tegaderm goes on there with as minimal as much touching as possible. And like I said, usually these are going to be secured with sutures. So the likelihood of you getting it in there, it's going to be very difficult. They're also not that big. But if you can get it to where it sits like this, and it creates that bacteriostatic ring around the insertion point, that's what you're trying to do. You're trying to impede the bacteria from the likelihood of the bacteria getting underneath that tegaderm from either sweat or them coughing or vomit or whatever it may be. Bacteria will eventually start to migrate up towards that little hole. That's why you need to change the dressing so frequently, every week. You don't just let them sit on there for a month. And this little portion of chlorhexidine basically creates a ring to kill anything that gets in that area. But if this is getting overly saturated, so say you have a patient and you have a brand new dialysis catheter and they're bleeding a lot, and it's still bleeding there because they're having coagulation issues, then you need to change this more frequently. Because as soon as this thing gets saturated with blood, it's ineffective. It's not working anymore. If the patient is sweating profusely for whatever reason, and you look and you see and it looks like just a big soggy mess, and you can actually see condensation on the inside of the dressing, you don't wait till Sunday to change it. You change it right now. Does that make sense? You always want to make sure that the integrity of the line stays intact, because whoever put it in there, they took a lot of great time and effort, and they already introduced infection to the patient by putting a hole in them, and it's our job to make sure that this stays as clean as possible. You don't want to have, bacteria migrate in this, so that's the whole point of using these things. Once you have the chlorhexidine patch, if appropriate, placed on the patient, and like I said, if they're allergic to everything under the sun, you're going to end up using a gauze. The gauze looks like this, and you would have the gauze to where it goes right over the top, just like that. To where that whenever you take off the dressing, it comes off in one piece. You don't want to like tuck it underneath there and then tie it in a bow or anything like that. And once you're done, you have your Tegaderm. The Tegaderm will go right over the top. You want to kind of just try to center it right on there. You peel off the label all the way around. And every company uses a different type of securing device, Tegaderm. The ones that we have now have a multi-stage securing device. So it comes with a little piece of plastic in the very bottom portion, and it opens up into a little V for the lines, and it's got hard plastic here, and that creates a more secure environment so that you can't pull on the lines, and you also get another little piece that folds over the top of there to further make it secure, to where if it accidentally you're pulling the patient up and you do that, it's not going to pull the line up. In case the line's not sutured in completely, because there are some cases where patients get lines placed and they can't suture them because of the direction that they're in. You're going to make sure that you write your name, date, initials, time, put that on there, put that on the side. You take off your gloves and do that if you want to, and write on there. And then you just take all your equipment and you throw it all away. Make sure you educate the patient about proper cleaning of the site, making sure that they're coughing or sneezing. Always try to turn away if they're drinking something. Don't have the drink holding over there. Don't eat over their site. Especially with subclavian lines. Also, patients that have ports, we didn't talk about this earlier. When they have portacasts, that is an advanced practice where once you guys go to your respective hospitals, you'll be taught how to access these. Okay? And whenever you actually are feeling for those, patients can sometimes have a pacemaker underneath their skin on the left side. They can have a port on the left or the right. And whenever you're feeling for that little bump, if you feel for it, this little portion here, and you feel like a little triangle, that means it's a power port. That means it's able to be going. You can take the patient to CT and they can do power injectables. They can go to MRI and take power injectables through there. If you don't feel that little triangle there and they don't have a card stating what it is, you can't use that for MRI or CAT scan. And depending on when's the last time that they had it accessed, like if it's been years since it's been accessed, most doctors, because you have to have an order in order to access a central line like this, they won't write an order for you to access that central line. But in most cases, when patients come into the hospital, it's usually either already accessed or it's been accessed in the last week or two. So you can always access that only with a doctor's order if you need it for central access. And typically you're only going to be putting a single lumen on there, and sometimes it'll only be for emergency reasons. Other than that, patients will either get a central line of some sort, or they can have peripheral IVs. If they can't have any peripheral IVs because they're waiting to get a fistula on their right arm and then their left arm is completely just shot, then you're going to ask the doctor if you can actually access the central line that they have. And you always want to make sure that whether the patients come into the hospital, the initial x-ray or initial CAT scan or whatever states that patient has a portacath and it terminates at the SVC, you want to have that radiological confirmation before you just go and start trying to access something that you have no idea of what it is. Okay, but that's an advanced skill. That's something that the senior nurses, and you'll have skills labs and stuff like that whenever you guys enter the hospital, where they'll teach you how to do that if that's something that you guys do a lot. And typically it's on the oncology floors.
So you're poking them through the skin
Yeah.
into that.
Mm-hmm. Yeah. So, and that's what makes it a little bit, you know, some people don't like doing it because there is an audible pop. You'll put the needle in there and it's like crunch, crunch, pop. And it goes right inside there. It doesn't hurt the patient because it's so close to the superficial portion of the skin that, you know, there's maybe like a millimeter or two of actual flesh that you're going to go through. But whenever you actually put it inside the port, it's like a little pop. So some people are like, oh, I didn't know if that went through the breastbone or it went through a rib, so they don't like to mess with it at all. But it's very easy procedure to learn how to do. It's just, that's a full sterile procedure, and it's a whole different way of learning how to actually access something, and the way that you go about doing it is different. Yes?
So they put that in via surgery? Like
Yes,
they cut them
yes,
open
yeah.
and place
Mhm.
that in.
Yeah. Yeah.
Just take it there and wait for it to go
Yep.
inside.
Implanted, yes it is.
And then for the little circle right there, what